afternoon, good evening. Welcome to the event, No Peace of Mind, Mental Health Under Military Occupation and War, and thank you so much for joining us. I'm Ellen Roskam. I'm the coordinator of the Global Health Program at the Global Health Center at the Geneva Graduate Institute. Mental health has been a neglected area of global health, not receiving the level of attention it needs and deserves. Today's event will focus on the mental health of people living under occupation or war, people who are particularly vulnerable to mental health problems. Through examples in 3 particular regions, our esteemed experts will discuss the realities of the mental health needs and challenges on the ground in those areas. The recording of the event will be available on the Global Health Platform website, probably by the end of next week, just due to the Easter holidays coming up. It's ghplatform.org. We will have a Q&A session later in the event, which will be open to the whole audience. Please type your questions or comments in the chat box, including any questions or comments you might have addressed directly to an individual speaker. So I'm delighted to introduce our moderator today, Edna Fernandez, who is the co-founder of Beyond Conflict, the mental health charity for conflict zones. Edna is a journalist and an author, and absolutely statistically nearly impossible for this particular event, has personally worked in the 3 regions that we will be discussing today. We're 172 people registered for the event today. So Edna, thank you for joining us. The floor is yours.
Thank you, Ellen, and thank you everyone for joining us today. It's a great pleasure to be with you. Today, as Ellen said, we're going to be discussing with 3 experts the mental health situation and particular struggles in the occupied Palestinian territory, Jammu and Kashmir, and Ukraine. We'll be looking at the role and responsibility of humanitarian organizations and in terms of response. We'll be looking at the longer term implications of insufficiently addressing mental health during occupation or war for individuals, families, and societies, and the role of global actors or policy processes in better addressing the mental health crises generated by occupation and war. Providing us with insight from the perspective of a global humanitarian organization, I'm delighted to welcome Mariana Duarte from Médecins Sans Frontières. Mariana, can I hand over to you? Thank you.
Thank you. Can you hear me? Yeah. Good afternoon. It is an honor to be opening this event today. I would like to turn our attention on this crucial topic, mental health in areas of military occupation and war. We live in a time of multiple humanitarian emergencies, many of which are consequences of armed conflict. More than 80 million people globally are often forced to leave their homes in extremely difficult conditions and to live without access to even the most basic essentials for day-to-day living. Having already faced stressful events, refugees and internally displaced persons may encounter additional stressors of poverty, discrimination, violence, food and resource insecurity. Added to these challenges, the conditions in which many people in conflict areas live on a daily basis are the incessant sound of explosions, constant uncertainty about personal safety, and the frequent loss of loved ones, leaving deep emotional scars. Consequently, these communities face adversity on multiple fronts, increasing their risk of developing mental health conditions. Nearly all those affected by humanitarian emergencies experience psychological distress, with 1 in 5 likely to develop a mental health disorder, such as depression, anxiety, trauma-related disorder, bipolar disorder, or schizophrenia. Vulnerable populations, such as children, women, elderly individuals, and those with pre-existing mental health conditions are particularly susceptible to the adverse psychological effects of emergencies. Mental health is an essential component of human well-being, and yet it is often relegated to the background in conflict situations. Resources are scarce, healthcare facilities are overwhelmed, and stigma around mental illness persists, preventing many from seeking help. MSF is providing mental health care aligned with humanitarian principles such as impartiality, neutrality, and independence. It emphasizes the holistic well-being of affected populations beyond just physical needs. Access to mental health care is recognized as a fundamental human right, and emergencies should not impede individuals' rights to receive appropriate support. It is therefore an imperative that we do more to ensure that mental health services are accessible and culturally sensitive in conflict areas. This means investing training for mental health professionals, providing psychological support for survivors of violence, and promoting mental health awareness to reduce stigma. It also means integrating mental health care into humanitarian aid initiatives, recognizing that physical and emotional recovery are equally important for rebuilding lives and communities. Access to medication for mental health conditions in humanitarian contexts remain a critical challenge. In these settings, individuals with mental health disorders often face significant barriers in obtaining necessary medication, leading to exacerbated symptoms and prolonged suffering. In addition, it is vital that actors and governments work in collaboration to strengthen mental health systems. We cannot allow a lack of resources to be an excuse for neglecting the basic needs of people who are suffering. I would like to highlight here that deliberate attacks on civilians and care facilities is against international humanitarian law. This has been constantly disrespected in the recent armed conflicts. Hospitals and civilians are not a target. Stop bombing. Our responsibility does not end with the provision of services. We must also address the underlying cause of armed conflicts and work tirelessly to promote peace, justice, and reconciliation. Only by addressing the roots of conflict can we hope to create a world where mental health is protected and valued. Integrating mental health into emergency response requires collaboration among various sectors, including health, social services, education, and community organizations. This interdisciplinary approach ensures a comprehensive and coordinated response to mental health and psychosocial needs. Mental health in areas of military occupation war is a matter of humanitarian urgency that requires our immediate attention and sustainable action. I'm looking forward to hearing today's speakers. Thank you.
Great. Thank you, Mariana, for that excellent overview. And before I turn to our speakers, I'd like to start by telling you a little bit about our work at Beyond Conflict, which was inspired by the experiences of 2 refugees from Iraq who fled territory occupied and controlled by Islamic State back in 2016. The first refugee was a young Yazidi woman who had escaped sex trafficking, and I met her at an IDP conference at Windsor Castle in 2016. And she was full of rage, and she felt that her people's voice was not being heard. So when I asked her privately what was the one thing that would make a real difference to people on the ground, she surprised me because she said, we simply need more psychiatrists. Our people are drowning in memory, she said. And even when they reached a place of safety, they remained caught in a cycle of horror and trauma with no way out. The second story I want to share with you is that of a 10-year-old orphan boy who escaped ISIS and got to an IDP camp. For 3 months, he did not speak. And one day he barricaded himself into a room with 2 small children, aged about 2 or 3. And when the aid workers finally broke down that door, they found the boy had hanged the 2 small children. So the 10-year-old was repeating the cycle of terror and violence that he had learned from ISIS. And those 2 stories led to a group of us to form Beyond Conflict in January 2018. Through these 2 refugees, we first learned about the lack of mental health support for victims of war and conflicts around the world. In the last 5 years, our small charity has done projects with partners supporting widows and orphans in southern Iraq. We have helped Rohingya refugees and frontline workers who fled a genocide in Myanmar to a camp in Bangladesh. We have helped Ukrainian refugees who have fled the war. And in January 2024, we supported 2 new projects, one for Palestinians in the West Bank and one for Israeli youngsters impacted by the Hamas attack on the Nova Music Festival. In all cases, we support expert partner organizations on the ground who know the cultural landscape inside out. Yet despite growing awareness and an understanding of the long-term cost of failure to address war-related trauma, the huge demand for mental health support remains largely unmet. So let us turn now to our distinguished experts who will give us a detailed picture of their work in 3 critical regions in the world and demonstrate clearly why things have to change. So our panelists today, I'm honored to introduce them. Firstly, for the occupied Palestinian territory, we have Mohammed Murray, mental health consultant and assistant professor at the College of Medicine and Health Sciences, Anajar National University, Nablus, West Bank. For Jammu and Kashmir, we have Saiba Varma, associate professor of psychological medical anthropology, affiliate faculty in global health and science studies programs at the University of California, San Diego. And for Ukraine, Dmytro Martsenkovsky, assistant professor at the Department of Psychiatry, Bogomolets National Medical University, Kyiv, Ukraine. And you can find all of their bios on the event webpage. So may we begin with Mohammed. Mohammed, could you tell us a bit about the mental health challenges and obstacles existing in the occupied Palestinian territory, and particularly focus as well on which groups are most vulnerable?
Yeah, thank you very much for this important event. Here in Palestine, unfortunately, people feel that they are voiceless and their voice not being heard or their story not being told, especially in the mass media or in the news. I'll give you two examples here, maybe in the West Bank, not in Gaza. The Gaza is more catastrophic what's going on. A child, his name is Muhammad Abu Khair. He was going to school. He's 14 years old. He's been caught by the settlers and they force him to drink gasoline and they set fire in his mouth. And they burned him to death. The other story of Ahmad, he's also survivor, the only member survivor from a similar accident. They were sleeping in their house. The settlers and soldiers, they attacked the village, Doma village. Then they basically they burned the whole family member where they are sleeping. The only survivor member, he is Ahmed, and he has to live with scars in his face and all over his body, but also he has to live with mental health scars, maybe the rest of his life, of what happened to his family. What's going on in Gaza is a genocide and ethnic cleansing. I'll give you an example what we mean by that. They were an only hospital in psychiatric hospital in Gaza. This hospital was bombed by Israeli army, and the weapons were being used, which is sponsored by UK and another European country or America country. This hospital was bombed. Most of the nurses and doctors were killed who were in the shift. Many of the patients were killed. Then the other fled in the streets without medication. So they will die either from hunger or from the snipers who shot anything move in the streets. The psychiatric patient in Gaza are living without medication. Children are doing operation to them, amputation without anesthesia. Women are doing cesarean section without anesthesia. This catastrophic situation leads to death, or the people live with mental health scars, maybe for the rest of their life. Nearly all the hospitals in Gaza is being destroyed or demolished by bombardment. So we can say there is no healthcare in Gaza, there is no mental health care in Gaza, there is no medication, especially psychiatric medication in Gaza. In addition to there is no food, there are 100 persons till this moment die from hunger. 28 of them are children. So people are living without, the basic needs, without water, clean water. There is no clean water before the 7th of October in Gaza. They were under siege for 17 years. And also the silent ethnic cleansing and silent genocide, which is not covered in the media, is going on from 1948 and 1967. So the people still
May I
suffering.
interrupt you there briefly, because we're running slightly over, and obviously
Yeah.
the trauma and suffering in your territories are huge, but may we be able to switch over now to Saiba, who could describe the situation in Jammu and Kashmir, and you will be able to continue talking a bit more later on in the session about the mental health aspect of what is happening in those territories. So can I turn to Saiba now? And in addition to the challenges and obstacles in the Jammu and Kashmir region, could you talk about how the local population views mental health and how that affects provision of healthcare as well? Thank you, Saiba.
Sure. Can you see my screen? Okay, I hope so, because I can't see anyone now. Thank you so much for inviting me to be on this panel. I'm really honored, and thank you to my fellow panelists as well. When we hear the stories and we know what's happening in Gaza when the bombs are still falling, sometimes it can feel very difficult to talk about mental health. It makes you sometimes question why, why is this important given what people are going through? But I have to always remind myself that it's what happens after the bombs stop falling that, that's when in many ways the real struggle of people starts. So I just want to keep that in mind as well. I wanted to also just begin with a broad contextualization of how I, as an anthropologist, am thinking about the relationship between mental health and war and occupation. I think something that connects all of our different conflicts is that we are all living today within a state of global perpetual war. This form of global warfare is very explicit in the sense that it is a war on the psyche. It is a war that targets people's perceptual, reasoning, decision-making, and behavioral capacities. It is very explicitly a war that does not only target soldiers and combatants, but ordinary citizens have become the targets of this war. And I just wanted to name the fact that, even, for example, the question of what do we call a conflict? How do we name a conflict? In the region of Jammu and Kashmir, for example, the Indian government does not see it as an ongoing occupation. It does not see it even as a war. It sees it as a place of terrorism. Whereas when you talk to people from Jammu and Kashmir, they will name this as a war, as an occupation. So I just want to say that even the ways in which we name these conflicts are so, it's so sort of imbued with with ambiguity, that I think that is where, in many ways, the sort of psychic assault on people's ability to reason and make sense of their world, that's where it really begins. In terms of the mental health challenges that are particular to Kashmir, but certainly not unique to Kashmir, as we know, a lot of the research on trauma and PTSD comes out of populations who are refugees, who have fled the place of violence. Whereas what we see in a place like Kashmir is that traumatized populations must continue to live in the traumatic environments. They don't get to leave, and that produces a unique set of mental health challenges. And I think that forces us as experts to think much more, not just about these discrete events that happen, a bomb goes off, or there's a confrontation between armed forces and rebels, but rather on the sort of atmospherics or the environments in which people are living and the ways those become almost unmanageable or imbued with ambiguity. So I just wanted to kind of highlight this as being about, I'm very interested in the structural conditions that lead to mental health problems, as Edna also mentioned earlier. And I think here we're talking about a kind of battle for reality between people who are living under occupation or war and the people who are controlling those places. And that this battle for reality is an ongoing thing. We're seeing it around the world. It is key to the dismantling of democracy and rising authoritarianism. I wanted to just also highlight that the vulnerable populations in Kashmir, as in other conflicts, children and youth, we're seeing very high rates of substance use. Women, we're seeing increased rates of self-harm. And particularly what we're seeing more recently are the ways in which political activists, journalists, medical professionals, and others are being criminalized for speaking out. And they're actually called narrative terrorists by the Indian government. So that has a unique kind of set of mental health challenges as well. Finally, I just wanted to say, in terms of the kind of humanitarian landscape that we're seeing, I think it is an imperative to decolonize global health and to decolonize humanitarianism. Perhaps we'll get to talk a little bit more about that later, what that means. I think Mariana mentioned already that humanitarian organizations are experiencing a lot of constraint. Spaces of neutrality and care are being either deliberately targeted or are eroded over time because of the effects of militarization on those spaces, in terms of, who can access a hospital, what kinds of medications are available, is there a curfew, is there a strike, all of those kinds of things. I see that humanitarian organizations also have a strong dilemma. They have to balance between how critical can they be versus accessing these spaces. So that's a constant negotiation that has to happen. I also wanted to touch on the fact that we talk a lot about stigma around mental health. And I think it's very important to recognize that that stigma is not only a cultural thing, but it's also a historical thing, in the sense that a lot of apprehension people have towards particularly biomedical, Western medical psychiatric care has to do with histories of abuse in psychiatric institutions. Just in India, for example, it was only in 2001 that the Indian Supreme Court banned the use of restraints in psychiatric hospitals. So that's very recent, and people remember those histories, and that contributes a lot to their apprehension in seeking care. I also wanted to acknowledge that humanitarian mental health care is very limited in scope. It's not always able to provide health and mental health in the way in which local populations understand it. And in the case of Kashmir, as with many other places in the world, people define health much more broadly than just being about the absence of symptoms. For them, health means it has a social dimension, moral, spiritual, psychological, and political. So all of those dimensions will also require attention from humanitarian organization.
Saber, would we be able to move on to Dimitro, because we've got a bit of a time constraint, and would you like to wrap up, or?
Yeah, if I just have two little points. I just wanted to say that we, I think, need a lot more focus on the positive aspects of how people living in these contexts survive. So some of the things that I heard from people in Kashmir were, for example, patience, cultivating patience, forbearance, hospitality. These are kind of critical coping skills that I think need a lot more attention. And then finally, I think the thing that I heard most often from people while I was doing my research was this idea that we will not be healthy until the conflict leaves us. So I'll just stop there.
Thank you, Soba. Thank you very much. And now could I turn to Dimitro? Dimitro, would you be able to describe for us the mental health challenges and obstacles that are happening in the war zones in Ukraine? Are people willing to use mental health care services if they're available? And could you touch on the fact, obviously, Ukraine's First Lady has taken a global lead on this issue, but has that helped to remove the stigma attached to mental health care in Ukraine? Thank you.
Thank you, Edna. Thank you, everybody joining today's event. So definitely, I would like to echo the previous speakers, and especially Mariana Duarte, who mentioned about stop bombarding the civil population. Unfortunately, the same is happening in Ukraine. Civil cities, especially those in the eastern part of Ukraine, are heavily bombarded. And it includes bombardments of hospitals, including psychiatric mental health hospitals as well. And talking about the most valuable population, we are definitely talking about people with pre-existing mental health conditions. So lots of those who honestly were suffering with various mental health disorders, they exacerbated as a reaction to the conflict. And it happened long before the full-scale invasion. I would like to remind that this war has started in 2014, and since 2015 to 2022, it was more like a frozen conflict. And like in 2022, there were lots of information in the mass media about the ongoing escalation of the conflict that negatively impacted a lot of people. With the start of the conflict, during 1 month, more than 10 million of Ukrainians were displaced. Some of them left their homes by their own, seeking for safer place for themselves and their children. Other one had to were displaced by the occupational forces or were stuck in the occupation. And lots of these people, unfortunately, were tortured. Lots of them lost their relatives due to, again, bombardment, active military fightings. Some of the people died due to the lack of medication or access to fresh water and food. And like this, the war that is happening now is exacerbating all those problems that we had before everything started. I mean, Ukraine has inherited a Soviet-based type of mental health care, and it was very institutionalized. So basically, like if you needed mental health, the only place that you could afford for any kind of mental health support was hospitals, mental health hospitals. With the onset of military actions, cities were bombarded heavily, and there were no possibility to access the hospitals. Internet was not working, like electricity, there were lots of blackouts. So people had to stay like sometimes almost all the day in the shelters. And definitely they started reacting with increasing anxiety, depression, and post-traumatic symptoms. Lots of them tend not to seek professional care, even if they needed it, because of the priority of physical safety over the mental health needs. Furthermore, like we are talking also about mental health literacy. It's very easy to explain that I'm having this or that symptom, and it's normal to have this in this situation when constantly, like my city is under bombarded, I can be killed at any point of time. And despite it's almost like 2 years, even more than 2 years, that like we see the escalation of the conflict, people are still have lack of literacy and they tend not to seek for mental health care. Another issue, as you mentioned, like is a stigma. And Ukraine has a very stigmatized mental health. It also has some historical roots, but also a lot of people are afraid because for them, seeking for mental health is showing that you are weak, that you are not able to cope with your conditions by your own. Now, like, there is a lot of changes, and thanks to our First Lady, who is a very powerful symbol of attention that now our government pays to the mental health. She provides a lot of humanitarian efforts, also like with the psychoeducational activity, and there is a very powerful mass media company supporting the website called like How Are You program that provides information on basic information on mental health and self-care techniques that can help people, even those who are feeling anxious or fear to seek for professional care, to receive at least basic interventions to try to cope with their conditions. We also provide lots in education of family doctors and other medical specialists in terms of the mental health gap program to teach them to provide like basic intervention, mental health intervention, to increase the accessibility of care. And this is like on the moment one of the core priorities, because we had a lack of human resources even before the full-scale invasion, but with the beginning of new phase of war, most of the specialists, especially those who were women, they were either displaced or left the country with their own children seeking for shelter and safety. So
if I could ask you just to wind up, because we are moving on to the panel discussion, and so if you would like to tie up your thoughts, thank you.
Yeah, definitely. I mean, generally, we always see the ability of local mental health systems to cope with the increasing amount of demand in mental health system. And generally, like all the groups of the population suffer, but like the most vulnerable are children and senior people, usually those who are not able to find any kind of care. Thank you.
Thank you. Firstly, I'd like to thank all our speakers for those extremely powerful presentations, and it is very important to include some of these particular case studies of individuals who've been impacted in each of these conflict zones. But I've had some feedback from some of the participants asking if we could have trigger warnings. So if you are planning to illustrate your point with a particularly harrowing story, and this applies to all of us, perhaps give a bit of a trigger warning. I'd now like to open it up to a wider discussion. There's a lot of overlap between each of the areas, and you seem agreed on a number of points. And I guess the first question I'd like to begin with is, what are the long-term consequences and risks of conflict-related trauma in civilians if they are left untreated? So maybe we could kick off with you, Mohammed, and then to Saiva, and then to Dimitro. Thank you.
Yeah, shall I start it?
Yes, please.
Yeah, I think in Palestine, the catastrophic situation here, the local people, describe it as a Holocaust. It started in 1948 and it is ongoing, is never stopped. In 1967 and so on. So the trauma is not much like, PTSD, something is being trauma and is being finished. No, is an ongoing trauma. And I live here in Nablus city, for example. People here feel that they are living in a sanitation camp because personally, I was unable to move. outside my city since 6 months. I feel suffocated, unable to travel. And also, there is a limited goods is available here in the city, as you know, it's surrounded from all sides by military barriers, and also settlers who attack anyone move in the streets. So also that in Gaza, we described a little bit about what's going on there. So in Gaza, there are many last 20 years, we can say there is a continuous bombardment every 3 or 4 years to the local people. So people not recovered from the last trauma, then they have a new trauma and new trauma and new trauma. And each trauma is maybe difficult than or more severe than the past. People living in the streets without shelter now, without food, without a place, a safe place to go, especially the children, without health care, without mental health care, in addition to you know, the limited supplies the military allow to cross the border from Egypt or from you know, from the sea. So this accumulation of feeling of hopeless, helpless, hunger, and oppression among the local people is something collective. Nearly all people here affected or influenced from what's going on of, you know, they describe it as a Holocaust or genocide or ethnic cleansing, but not being mentioned in the media or well presented in the mass media, especially in the European
Could we open up to
news.
Cyber and to Dimitro as well to hear about their perspective on the long-term consequences and risks in their regions? Thank you. Cyber?
Yeah, sure, I can go next. I think it's important to specify what we mean by treated when we use the word treated. I think it's very important for us not to limit our understanding of treatment to just biomedicine, to Western medicine, to Western psychiatry. There are many ways in which people cope and grieve and mourn, even in spaces of war and occupation. And I think we need to pay more attention to those spaces. You know, a woman in Kashmir can go to a shrine and weep for hours and nobody is going to question her. No one's going to tell her to move off. There's a space, an established space, and established ways of dealing with trauma, all of which are being attacked, all of which are being eroded over time because of militarization. But I think it is very important for us not to lose sight of all of the rich kind of cultural practices and strategies that people used. I just also very quickly to your question, Edna, about the long-term effects. I think, like Mohammed said, it erodes people's capacities on a very fundamental level, right? Robert J. Lifton, who's an American psychologist who did a lot of research in Hiroshima after the atomic bomb, and he talked about how actually the impact of Hiroshima was much more psychological than it was physical. And he said what happened to survivors of Hiroshima was that, he uses this phrase, they lost faith in the structure of existence. And I think that on some level happens to everyone who's living under these kind of long-term conflicts.
Thank you, Cyber. That's a very powerful point to end on. And can I turn to you, Dimitro, for your view on that?
Thank you. I'm fully agree with Cyber, and I think that probably we shouldn't talk about people that were treated, but probably more about recovery from the psychological wounds of the war. And definitely it will take decades for most of the people to fully recover, like in terms of achieving of their well-being. And in this case, we are talking not only about like symptoms of those or another mental health disorder, but we are talking about the possibility to enjoy the life again, to have a proper sleep, not waking up from the nightmares, to work for the prosperity of their families and communities, to interact and to have a stable belief in the safe future. Because with the times that conflicts going on, less and less people are able to see the future for themselves and their children, and more difficult becomes for them to cope with everyday challenges. I'm not talking about the challenges of the war. I'm talking about the everyday challenges, about the conflicts in families, financial difficulties that all of us can face at that or another point of time, in various situations, and this will affect most of those who were traumatized by the war for many decades, and as Mohammed mentioned, sometimes for generations, because we already see that in most of the countries that were involved in the war, we have at least several generations that were impacted by the same conflict to those or another degree. Thank you.
Thank you. And some of you have already touched on this, but the stigma around mental health, it's global, but it's also particular to each of the places that you're coming from. Can you talk about how you overcome this in a complex scenario with civilians who might be suspicious or resistant because of cultural or religious factors? How do you deal with that? So could I open that up to the three of you?
Yeah, in regard to the stigma, there is a stigma here in, occupied Palestine as other places in the world, but maybe here is the context of the stigma is different. What we mean by that, it's a chronic problem attached with mental illness, but it's need a strategic plan to, to deal with this problem. And also, and unfortunately, here in Palestine, the PA is basically controlled by the Israeli military occupation forces. So they have, if they put fund for to fight the stigma or to treat the stigma, they have a challenge that they will cut off, the money, and the healthcare services is politically bound. And also the PA is also based on European and America support, but this also is politically bound, unfortunately. When they put pressure on the PA, they stop this program which treat or fight the stigma, or even all the mental health service. I remember in 2006, there were no...
Could we stop there and allow Cyber and Dimitro to come in? And we're trying to kind of steer clear of the politics, despite the difficulties of that, because we have a rare opportunity here to focus on the mental health issue. So could I hand over to Cyber and to Dimitro now for their answer on this point?
Sure. So I think with stigma, it's very important to understand that stigma is not the problem. It's not just the problem of the culture. It's not that, these local cultures are superstitious and they're backwards and they don't understand Western psychiatry. They don't have a concept of mental health. I think that's really wrong thinking. And this was to my point earlier about decolonizing global health. A lot of organizations come in with that kind of attitude that there is no mental health, and so we have to create a concept of mental health. I think that's absolutely not right. The thing is that people have a problem. What I've experienced is that people have a problem when you label them with a cognitive issue, because they associate mental health with something that's psychological and cognitive. It speaks to a kind of lessened brain capacity, and that culturally just does not work. I think other approaches that we could think about are things that foreground much more somatic techniques that are more kind of culturally appropriate in places. We can think much more about non-verbal techniques. It doesn't always have to be talk therapy based. We can think about reintroducing rituals of mourning, rituals of healing into these kinds of care projects. So yeah, I just wanted to kind of say that about stigma.
Thank you, Sarah. Dimitri?
Yeah, thank you. As I mentioned, there is also like some historical part that affects the perception of stigma in Ukraine. Psychiatry for a long period of time in Soviet Union was used as a way of punishment. And now there is still a memory of psychiatrists who were dealing just with the political dissidents of the regime. And it still exists. It's much better now, like with decades after the collapse of the Soviet Union. Also, there is as I mentioned, there is a lack of health literacy and understanding. Lots of mass media, a lot of time mass media described mental health condition as a very severe, like mostly those that are related to the something very offending or criminal behavior. And most of the people do not want to be associated with those who have mental health issue because they recognize it as a something very severe, very fearing, scary. Also, like as Saiba mentioned, we are talking about some cultural issues, but in contrast to the Saiba's story, we in Ukraine probably see like more favorable approach in terms of using the medication among the population. So more people believe in meds than in psychotherapy or in some like recovery techniques or cultural things. It's changing a bit, and like we definitely as a country have over medicalization of mental health disorders, but still like we face a lot of difficulties when people do not believe in something they cannot, touch, like meds. They do not feel that it's working and maybe not so favorable in terms of using. However, again, it's changing, and younger population is having more and more demand in terms of the psychological practices. That is very important, especially taking into account that we do not have any really evidence-based effect of medication in terms of psychological trauma and working with stress-related disorders.
Thank you. I mean, the next question I want to ask you is, why do you think there is such a lack of resources for mental health in occupied and war zones? Because there is growing momentum. There are big voices that are now taking this on. Who's talking about it? Also you've seen people like the Ukrainian First Lady talking about it on a global platform, but still the resources aren't coming through in adequate amounts. And I wondered if you could talk about why you think that is, how much of an issue is that for you, and any recommendations you may have on how you address those capacity constraints on the ground. And I could open that up to any three of you.
Well, when the situation, the bombardment is going on, the health team usually focus on ABC, which is air, breathing, circulation, when they try to survive the clients. So basically, if a child has amputated leg, the first thing they think how to stop the bleeding and let the body of this child survive. Then maybe they don't have a time or capacity to work on mental health, health issue. And unfortunately, this is also bound with, stigma of, mental illness. When the medication is something is on and off, is not something continuous, that affects negatively how the local people here look to using medication or psychotherapy or even mental health treatment in general. So here there is a need to be a strategic plan for sustainable mental health services working in parallel with health services in the conflict or war zone, in order to accomplish or apply first psychological aid or first mental health aid.
Thank you, Mohammed. And Saiba, can I turn to you next?
Sure. So, I mean, it's a complex question, Edna, but I think very quickly just say colonialism is one factor. These institutions were set up during British colonialism. Psychiatry was always a very marginal part of the colonial medical system, which continues. It gets aggravated when we have the onset of neoliberalism, the underfunding of public health all across the global South. And you add conflict on top of that, right? And then of course, you have a crisis. But the third thing is there's also a deliberate withholding of care that I think all of us have seen in our context, which also I think contributes to that under-resourced nature.
Thank you. Dimitri?
Yes, thank you. I fully agree with my colleagues, but I also want to add that we need to be honest to say that mental health is extremely expensive part of well-being, and it's also not given like the quick results, as Mohammed mentioned. Like when we see the child with that lost a limb, and we can like operate it, and in a couple of months provide with a prosthesis, we can see like a quick results of improving the quality of life of this child. But with the mental health, this is more like investment in the future, like with many decades. We will see, like I'm strong supporter that those money that we invest now probably will give us some results in 10 years, probably like 15 years, but not in 1 or 2 years perspective. And again, we are not talking about politics, but we are talking about a bit of economics here. And usually like those who invest money, they want to have a quick refund of this money, quick results of these investments. But as we know, like most of the reforms in terms of the mental health, they gave it their results like within a decade.
Thank you very much, Dimitri. And I think we've had quite a frank and brutally honest discussion on all fronts. And I wanted to try and end this group session on a small note of hope. I wondered if you could describe an example from your region of where this kind of mental health support has made a difference on the ground, just to demonstrate the efficacy of some of the work that's going on in this field. So I'd like to open that up to the three of you.
Well, I remember an example of a child who's been treating, he has cancer. He came from Gaza to be treated here in Nablus city, and this child was alone because the military forces not allowing any company or his parent to be with the child. So the child he's in the unit alone, and he was depressed. Then they asked me to for consultation. And after doing intervention with the child, because he feel insecure, he don't know anyone in the city, and he's in cancer treatment or chemotherapy treatment, which needs someone to to nurture him, to partner him, to be with him during the process. The main treatment plan was to find a volunteer here from the city where the child is taking treatment, and just accompany him and nurture him, play with him, let him talk with his family when it is available on the video call, or if it is the internet is available. So that's alleviate a little bit the stress of this child and improve his mental health, which is basic steps or simple steps we took over.
Thank you, Mohammed. That's a very encouraging story to hear. And Saiba or Dimitri, would you like to share your own experience?
Sure. Probably, I think one of the hospitals I work in is it's a children's hospital in Kiev. And after like the occupation of Kiev region, they created something like supervision program over the Kiev region. So every couple of weeks, a group of doctors of various specialties, including psychologists, go to like small villages and cities that were under the occupation, and to provide like routine assessments for the population, for both adults and children. And it was fantastic to see how effective was this intervention when you can bring them, because again, we are going back to barriers of receiving the mental health care like in war affected countries, and the distance and inability to receive here like near your place of living is one of the biggest barriers. And when the doctor comes to you and provides some psychoeducation, for parents it may be like a very important part to see that something wrong is happening with their children, and it's not normal even in the conditions of war. And later the children's that were like pre-screened with the possible mental disorders were already referred for mental health assessments and received the proper care if needed.
Thank you.
And some of them definitely responded well to the intervention, both medication and non-medication, and now have a much better level of quality of life and well-being.
That's very heartening to hear. Thank you, Dimitro. And lastly, Saiva, if you could have a similar story to share.
Sure. And I'll just give a trigger warning. When I was in Kashmir in 2016, there were the military was using lead-coated pellets to disperse civilians, and a lot of young people got hit in the eyes and lost eyesight or were blinded. And I remember walking around the wards, the ophthalmology wards, and all of these young boys were sitting, these big bandages on their eyes and sunglasses on. It's like a row of them with these black sunglasses. And I overheard them joking about and singing the Men in Black song, the theme song, because they're like wearing the black sunglasses. And they erupted in laughter, the whole ward, in this, really intense, difficult moment. And it was such a powerful reminder to me about the sense of humor that exists in these places. And because I think sense of humor is just one example. It's not only a coping strategy, of course it is that, but it's more than that. It's a way of reclaiming history. It's a way of reclaiming your narrative. It's a moment where you can have some self-determination in a context in which you're so powerless otherwise. So I just want to end with that there are many, many such moments of everyday resilience that I think we can draw a lot of hope from.
Thank you, Saiva. It means a lot to be able to end this particular part of the session on a note of hope. And now we're going to open up the Q&A session to the audience. And while we've had quite a lot of questions already, but while people just type in their questions and comments into the chat box, including any addressed directly to a particular speaker, I'd just like to share one quote that was sent to Beyond Conflict for our Child of War exhibition in May 2024, and it'll feature the art and words of 350 kids portraying the mental health impact of all wars around the world upon children. So this is from Aisha, and this is her quote. "All I know is I'd be willing to be hungry, thirsty, and as much tired as it would take to have my dad back. I hope my mother's tears don't fall and my father stays close. I hope I can return home, the place where my memories await me. I hope they leave us alone. I don't want to play anymore, for I am a child of war." So let's look at some questions. If you just bear with me. Thank you. Right. So here's the first question. How does individual access to mental health treatment play a role in shaping collective healing and well-being? It's open to any of you. I'll
Can you
repeat the
please
question.
repeat the question because I didn't hear?
How does individual access to mental health treatment play a role in shaping collective healing and well-being?
Probably I can start that. Definitely individual access is very important. Again, we are talking about people that are usually like under very severe stress and under exposure to the danger of the life. And in this case, as Mohammed mentioned, usually we are talking about ABC. First, we are talking about physical safety, and all our mental health needs go to the as a last point of all our needs. So if we can propose more individual treatment and more easy access to the treatment, in this case, we can increase the chances that person will use the treatment. We very often see that in many countries that in war, lots of humanitarian organizations may propose various mental health interventions, but at some point of time, they are not fully lauded, again, because of the people are not using the services even if they proposed. And this, like a possibility to provide individual treatment, gives a possibility of something like a radio working. If you will help one person, he will share that it's possible to solve this kind of issues. He will share it within his network, and this network will grow and grow and grow, providing more and more people with a belief in this mental health intervention as a possibility to access the care and to get a recovery.
Thank you. Could we go to Cyber, because I think Mohammed is breaking his fast. So Cyber, would you like to take it up?
I think, yeah, I agree with what Dimitri said. I think I would just add that I think there is a tension between care that is happening kind of at the individual level versus care that is understood more collectively or socially, or that makes space for the relational lives that people lead. You know, so family therapy, for example, group therapy. I think that's sometimes there can be an over focus on the level of the individual because it's a sort of Western model. So that's the only thing I would add.
Thank you. And there's another question here. What can be done for primary prevention of trauma from conflict?
So probably we cannot talk about the prevention of trauma. We cannot stop the wars, unfortunately, at the moment, but we probably may try to work with the consequences of trauma. We may try to work with the resilience of people, with the ways of coping to make them more strong to deal with various negative effects of like the war, like natural disasters and other traumatic events. And this include, again, like we are talking about psychoeducation as the basic rules, because without knowing that your experiences is not healthy, is not normal, people usually not tend to use like even self-helping techniques that may be like very useful in terms of the conflict. We also need to talk about educating how people may use their surrounding to improve their mental health conditions. We are talking about educating parents on managing stress for child, creating safer places, managing routine, giving a possibility for proper growth and development. We are talking about possibility to encourage people to do routine things, to communicate, to interact with other people, to be meaningful. That is very important during the conflicts, like to be involved in volunteering, for instance, or doing any kind of job that is meaningful and important for the community or like the family or person itself. I think that like basically this is a very simple things, but they may make the difference in terms of resiliency of the people for trauma.
Thank you, Dimitri. Cyber or Mohammed, would you like to come in there, or Mariana as well?
Yeah, I think in regard to to recover or resilience of from trauma, I think the very important point here, because I just published a couple of papers about resilience, is something cross-cultural, and we need to be aware of that. And unfortunately, the mental health interventions is being funded in the war zone. Usually, it's been something can accomplished according to the funder interest, which is something wrong, because the intervention need to be culturally sensitive. For example, to explain what I'm saying, people in Gaza, they're using their faith in Ramadan and in other days as well to empower themselves, have high spirituality, and be able to keep going and continue their life. So in the mental health interventions, we will never see, European funders who support, for example, reading Quran or practicing fasting for the local people here in Palestine. Basically, what they are doing is copy and paste of the intervention in the Western country. So if anyone lost all his member in the bombardment, they encourage him to dance. But
Yeah.
no, there is no programs to encourage him to, if reading Quran alleviate his stress or improve his resilience, there is no such programs here in Palestine. And so if we need to do intervention, I think it need to be cross-cultural and sensitive to the cultural context.
That's a very important point. And I want to also open up, because obviously, Kashmir, Ukraine, the Palestinian territory, they are all in the news. But what about conflicts nobody knows about that aren't publicized? And I wondered, Mariano, if you could come in here. What about those that are forgotten conflicts almost? How can psychologists and psychiatrists around the world help in peace building activities or offer some kind of support in those contexts?
It's a very good question. Thank you. I'm just reminding now, because I just came back from Bangladesh, about the Rohingya situation.
Wow.
Is a community that is now forgotten, let's say, from the international media, and is years stuck in a camp. So they are not recognized as refugees in the hosting country, and they are not allowed to come back to their country. So the conflict, the violence inside the camp is increasing, and the population cannot move, cannot work, can do. So it is a very difficult situation. We don't talk about it anymore. But I think echoing my colleagues here and remembering that after a traumatic experience, it's not everybody who's become traumatized. So if one in 5, which is the average from WHO researchers, and is aligned with our database as well, we would require more specialized care, but the majority of the population, you can strengthen community building approaches, you can develop activities, as everybody here is sharing, that you bring back the ritual, the community engagement. You find local leaders that they are already very happy to, not happy in any situation is not happy, but I mean, they are very keen to support their own communities. So helping them to find ways to lead those activities. So I saw one of the questions in the chat from MSF. Yes, we are discussing more and more in the past years about decolonizing our activities, especially because MSF, it is a European organization as founding, but we are more and more nowadays. We have just 10% of expats. The majority of our staff are local because of that, because they can support their own communities. We can engage, for example, even for specialized care, we have the peer-to-peer approach. So you have people with mental health lived experience supporting other people in their own treatment. So you have different options, rituals, dancing, narratives. in my PhD research, one of the things from people who lost their loved in the war or historical ongoing conflict was this aspect of non-recognition of dehumanization situation. So they were feeling dehumanized and not recognized. So giving space for this narrative of recognition, recognizing each other, and remembering the ancestrality is super important for who is out of their own community or country. So there are many different aspects in the building efforts and recovery. So it's not just, as has been said here, the treatment. On the other hand, MSF, as I said, at some point we need to focus in something. We are a medical emergency organization. We focus in the most severe conditions, moderate and major, because in the situation of emergency and the moment of the conflict or the moment that the conflict is happening, the disruption of medication, disruption of treatments are very common, as we have said already. So we try as well to fill in this gap so it's both situations. You have community development-based approach and local strategies, but also we need to focus sometimes in those aspects of people who are stable will suffer even more of the disruption. So it's all the layers of the pyramid who is not about mental health. Here we call YASC, the interagency committee. So you have the pyramid of 4 layers of intervention mental health. We try to do in a holistic way. I hope I have answered.
Thank you, Mariana. That was a very interesting.
Sorry, could I just jump in there? I wanted to just echo what Mariana said about increasing representation amongst local communities themselves. I think that's really important. I think we do need to think about how we're training psychiatrists and psychologists as well. I think, like, in addition to kind of cultural sensitivity training, it's like these are the people who also have to become activists in the context in which they're working. In Kashmir, I've seen it many times where doctors are the ones who speak out about violations that they're seeing in whether it's firing protocols against civilian crowds or just violations of human rights, right? Like doctors have to become activists. And I know MSF has this kind of ethic of witnessing behind it, but I think like a lot of other organizations also need to think about how are we training experts, and can we actually, how do we also build capacity amongst experts so that they feel like they can speak out when they're seeing violations, you know, even if it means maybe access in some ways is compromised.
Thank you, Saiba. And this kind of leads quite well on to another question which all of you might find interesting. In mental health theory, there is the triangle of persecutor, victim, and savior in conflicts. These roles can shift over time. If one or the other side gains more power or succeeds in a military incursion, the question is how to break out of the triangle to stop the dehumanization of the other. Who would like to lead on that one?
Well, that's important question, I think, and it's been here in discussed in public way in Palestine. You know, all of us know that the Jews suffer from the Holocaust in Germany, but they came here to Palestine as refugees. Then they started to do a new Holocaust to the, unfortunately, to the Palestinians by the support of the European Union and America.
Let's not get political though, Mohammed, because otherwise we'll all get told off. But I mean,
what's that?
would anyone else like to jump in here?
Yeah, but that's something we have to discuss.
So probably
the Israelis came from, you know, the European country. They fled from the Holocaust, but they started a new Holocaust now in Palestine with the full support of the European countries. That's the fact.
How do we, I guess the key part of this question is, how do we stop the dehumanization of the other?
Well, we need to stick with the international law. We need to stick with the international law. We need to help the offender to let them stop.
Can I bring
Because
in,
maybe they are not aware of what they are doing.
can I bring in Mariana at this point, or?
Of course, I think this answer is much broader than mental health. So when we talk about those situations, there are all power disputes and other things that I won't address here. I think everybody's aware. But in terms of mental health, psychosocial intervention, what we can do, and I think in the end of my speech, I tried to highlight it, is the cooperation, collaboration among actors. So when you strain community, when you involve government, when you involve international actors, local actors, when you involve community, and you strain these voices, you can work in different layers of the need and deconstructing some layers that are happening of, let's say, reproducing the violence and dehumanization. So it won't, of course, change the entire world because an entire situation that we are talking now that is too big. But in terms, let's talk about a situation that we are working specifically, you can help the community to deconstruct some violence and repetition of violence, but this requires a collaborative effort from different actors addressing different needs as well.
Okay. There's a question here from the director of the Institute. To what extent can international humanitarian organizations develop and implement culturally informed mental health projects, given the often short-term nature of humanitarian aid interventions, funding timelines, staff contracts, etc.?
I think that's for me,
Yeah,
that's a very
jump
good
into.
question. That's a very good question and quite difficult to answer. And that's one of the reasons MSF was founded in 1971 independently, because we manage our own resources. Is true that many organizations, they have a huge effort, they are doing a great work, and the international funding stops and they have to stop the project. And this is so difficult in the field. And for me, now I'm talking about myself, is a repetition of a violence. When you break the process of intervention, you take you take out the power that you is quite sad to see that. And on the other hand, so for MSF, we face some limitations, but less because we don't have international funding. This is 100% civil society support, financial support. However, we're limited in other ways. But what we have changed and switched in MSF in the past years of intervention is how we can, and we are thinking more and more, and is also associated with decolonizing our speech and intervention, is how we can help with capacity building for the day we live for a sustainable intervention. So I'm going to give some examples in the past 10 years. We are working with internship programs for universities. One of them is Palestine in Nablus. What happened is many countries, during the conflict, the minimum of resources they already have is becoming nothing because of the context, and many professionals flee the country or the situation or the area. So you need also to work with capacity building among professionals. So MSF, we are trying to collaborate with the university. So an example of Liberia, Palestine, Jordan, we are working with the Ministry of Education to have internship programs in our facilities where the next psychologists, the next psychiatrists, the next social workers, they have practice, able to take over responsibilities and activities later on. We are rethinking more and more our strategies in being more integrated in collaboration with Ministry of Health. Sometimes our option is to be out, to be independent, but in many situations where the condition allows us, we are integrating MOH to train staff and to upskill, to take over the cohort when we leave. So we are trying more and more to do that. And I think that the past 15 years, it shapes a lot. We have more regular projects, which means not just emergency, is more long-term, that we have time to hand over to someone else, especially the health system, because we are a health organization, or another organization who can take over.
Would anyone else like to jump in on this question and add to Mariana's answer?
Yeah, if I can, I just want to say also that I think it's absolutely essential. There's no option but to have culturally informed mental health care. And that has to do with the fact that, as we've been talking about, mental health care is not like the other kinds of emergency aid, right? It's not like a packet of food or clean water. It's slow, it's long term, we don't see the results, right? All of those problems, which mean it has to be culturally informed. I'll also say that mental health in general, only a small part of that is biological and neurobiological, right? Most of when we talk about mental health, we're talking about social problems. We're talking about political problems, economic problems. Those are the things that really shape people's mental well-being. So if we're not addressing the social, political, cultural aspects, we're missing, then we're just addressing like the tip of the iceberg.
Well, thank you to all our panelists. We're coming up to the end of our session. And I'd just like to summarize a few points from today. I think all of you agree that the government and the international aid community need to reprioritize to put mental health near to the top of the agenda to help move capacity closer to the urgent and overwhelming need. And you've also talked about the importance of being culturally appropriate in each of the settings, and that's vital in designing any kind of mental health program for each region. Secondly, it's evident, and all of you have raised this, that unless this happens, the cycle of trauma will be passed down to future generations. We've seen it happen after World War I and World War II. We've seen it in every conflict around the world since. We see it in the kind of stories that Mohammed described. We've seen it in the story of the 10-year-old Iraqi boy that I talked about. And by failing to address the breaking of the cycle of war trauma, this merely increases the risk of the cycle of violence continuing into future generations. And it makes a building of a peace eventually that much harder. So maybe the world should see resources that go into mental health support for victims of war and occupation, not just as an act of humanitarian aid and charity, but actually as a future investment in our collective peace. And I'm particularly concerned, obviously, about the need for investment in helping damaged children and the young people, because these are representative of all our futures. So if we don't invest in these traumatized young people, really that doesn't bode well for the world in future. Thank you to all of our distinguished speakers for your passion and for your honesty. And I'm really grateful as well for the fantastic questions that have come through from a very engaged audience. We hope that you've found this event stimulating and illuminating, and an opportunity to think about the very particular, unique mental health needs of populations living under occupation and war. It's been a great honor to be with you, all of you here today. And thank you to the Institute as well for throwing a spotlight on this issue, which is so urgent today. So Ellen, over to you, and thank you.
On behalf of the Global Health Center, thank you all for participating today. Thank you, Edna, for doing an outstanding job moderating. This was not an easy event, and I would like to say the chat box has been on fire throughout, which is a really good sign. People have shown on our audience passion, a lot of discussion, different vantage points, suggestions, criticisms, ideas put forward. If you haven't looked through, it's worth scrolling through. So thank you again, and please join us for our next event, which will be the open briefing on the eve of the 77th World Health Assembly on May 26th from 11 a.m. to 1 p.m. Central European summertime. You can register for our newsletter at ghplatform.org to get the details of that and all of our events. It will be live streamed while being in person. In a moment, you will be directed to a very short survey. We'd really appreciate you taking a couple of minutes to answer just a couple of questions. The recording of the event, again, will be available shortly on our website, probably the end of next week because of the Easter break. And finally, I want to thank very much our whole team for making this event possible today. Negar Mansouri, Bettina Zago, Erica Schinabarger, and Tomasz Morochowicz. Thank you all, and we really hope to see you at the next Global Health event. Have a nice rest of your day or night.